In this presentation, I'm going to be speaking about one-to-one instruction. The objectives in this presentation is that the learner will understand the principles of one-to-one instruction, and the learner will recall the advantages in using one-to-one instruction. Also, the learner will recognize appropriate times in their day when to use one-to-one instruction with patients, staff, and students. Now, a description of one-to-one instruction is that it is only between two people, between the educator and the learner. It can be either a formal, such as a planned meeting or a planned appointment, or it could be informal, such as a teachable moment when the educator sees that there is a readiness to learn in the learner, whether that is a student, fellow nurse, or client. And it is a face-to-face delivery. It's interactive. The educator is the one that presents the information, and the learner also plays an active role. It's never a situation where it's a lecture where only the educator talks. It's usually between 10-15 minutes in length. The information is tailored specific to the learner, such as the learning style, the pace of the education, the review of information, the assessment of where they are in the stages of change, and there's also a contract made between the learner and the educator. And in doing so, with this contract, they can then design an action plan with each other, and they can also make defined roles and have expectations for each other and for each other's roles. And questions are also just a great technique to use to achieve the goal of learning. Questions should be a way of exchanging information and for the educator to help stimulate thinking in the learner. It shouldn't necessarily be a test for knowledge, because these questions should help stimulate thinking. They should be more than just yes or no questions. And then also with these questions, time should be given for the learners to process the information and to answer. So that's okay if there is silence, because the learner may be an internal thinker and processor. So they might think internally before they respond to the question. In one-to-one instruction, you actually hit all three domains of learning: the cognitive, affective, and psychomotor. So the cognitive, it is specific to the learner's mental capacity and the learning process. So the educator can ask the learner a reason behind giving a certain medication, such as why give a beta blocker to someone in atrial fibrillation, and how does this affect cardiac output? So this question is more of just a yes or no question. It's more of just testing their knowledge, but also this question helps stimulate their thinking. For the affective domain, they can use questions to address ethical decision-making and moral dilemmas, such as educators can ask questions related to like if a diabetic patient is eating multiple chocolate bars that the family brought in, how would you address the patient and how would you address the family? How would you care for a patient who is unresponsive, being an IV drug abuser, and the patient has been unresponsive for days, yet the family continues to want the patient to be a full code and get all the interventions necessary to keep them alive? So these are just example questions of how the educator can stimulate thinking in the learner and within the affective domain. In another domain, the psychomotor, the learner can demonstrate a learned skill. This is more hands-on between the educator and the learner, such as how to start IVs, how to prime IV tubing, and also how to perform how to perform tracheotomy care. Now, advantages in one-to-one instruction is that it is tailored to meet the individual needs, such as we said before, like the learning style, the pace of learning, and the specific stage of change that the learner may be in. Another advantage is you can use all three domains. Useful for learners who have low literacy or educationally disadvantaged. There can be immediate feedback between the learner and the educator, such as the learner can let the educator know if the style or the pace is good for their learning, or if something needs to be changed in the way that the educator is asking questions or how they are providing the information. And the educator can also let the learner know how they are improving in their learner, and also provides accurate initial assessment and ongoing assessment of the learner. So the educator does not have to adjust their teaching based upon 5 to 10 to 15 students, however, just one client. However, the disadvantages to one-to-one instruction is that it isolates the learner, puts the learner on the spot. The learner can start to feel anxious, and questions can overwhelm and potentially confuse the learner. The learner is unable to bounce ideas off of their peers, and learners also can't identify with others and share their feelings or their ideas about the information with other clients or other students. They're by themselves, and with isolating themselves, as I said before, it can cause anxiousness. It is also economically expensive, because if you have one nurse precepting another nurse, there's a lot of, it's just very labor intensive to train the new staff, and also for educational personnel to perform continuing education with staff. So although it's vital for professional growth, for a preceptorship, or for continuing education with staff, performing one-to-one instruction for continuing education may be expensive for the organization to utilize the technique. And also the educator might not be proficient in educating. So the educator, such as another nurse, may be great clinically, very skilled. However, they're not skilled with teaching and exchanging information and stimulating thinking in learners. Examples of one-to-one instruction are a nurse to a patient or a client. So this could be in a doctor's office, or this could also be in acute care, such as within the hospital. And there was a report by Catherine Lingle in 2013 that showed one-to-one instruction by a nurse educator to a patient for 1 hour that the education by a nurse educator to patient for 1 hour. So although it's a little more than the 10 to 15 minutes that I said before, that is usually with one-to-one instruction, this study did 1 hour. But they spent 1 hour, and with the discharge instructions, it resulted in improved clinical outcomes, increased self-care, measure adherence, reduced cost of care for patients with heart failure, and also reduced admissions. Another example would be a new employee orientation. So you would have a skilled nurse and a new nurse, a student preceptorship. So this would be between a clinical nurse and a student nurse, and then also with continuing staff education. With all 4 of these examples, all three of the domains of learning can be incorporated into the style of teaching to help stimulate thinking and exchange information. So one important thing also, that it's not necessarily the quantity of information that is given between the educator and the learner. It's more important about the quality of education, or the quality of information that is exchanged between the two. And this is the references for my presentation. I hope you enjoyed it and you learned about one-to-one instruction